Welcome back to the deep dive. Today, we are opening a file that I think everyone dreads, but it's one that is just absolutely essential to understand.
It really is.
We are tackling Alzheimer's disease. It's a term that carries so much cultural weight. It's practically synonymous with aging in the public imagination. But when you actually look at the clinical literature, the reality is far more specific and, frankly, far more biological than the general conversation suggests.
That is the perfect place to start. There is this fog of fear around the word Alzheimer's, but our job today is to cut through that fog with precision.
Right.
When we strip away the emotion and look at the pathology, we aren't looking at some unknowable mystery. We are looking at a very specific mechanism of failure in the brain.
And that's our mission today. We are going to deconstruct that mechanism. We have a stack of clinical texts and research papers here, and we're going to map out the biology, the why.
The why, right.
Then move into the progression, the what, and finally we need to have a very sober conversation about the reality of treatment.
Yeah, that's a tough one.
But before we get into the microscopic details, let's start with the definition. Because reading through these papers, it struck me that Alzheimer's and dementia are, well, they're not synonyms, though people use them that way all the time.
Right. That is distinction number one. Dementia is the umbrella term for a set of symptoms: impairment in memory, communication, thinking.
So dementia is the what's happening, not the why it's happening.
Exactly. It's the description of the problem. Alzheimer's disease, or AD, is a specific biological entity. It is a progressive, fatal dementia.
Fatal. That's a word we need to pause on.
We do. And based on the literature we have, the key distinction that separates AD from other forms of cognitive decline is that it involves the loss of both cognitive and physical functioning.
That physical component is something I think gets completely lost. We focus so much on the memory loss, the who am I aspect of it.
Of course. It's the most poetic, the most tragic part.
But the text emphasizes that this is a systemic breakdown of the self-maintenance machinery.
Exactly. It's not just, I forgot where I put my keys. It's a decline in the body's ability to perform the basic algorithms of life-feeding, moving, recognizing sensory input.
So the brain is the control center for everything, not just your autobiography.
That's it. When the center fails, the body's ability to maintain itself fails with it. It encompasses behavioral symptoms just as much as memory.
Now, usually when we talk about a disease this devastating, the immediate assumption is, it's in my genes. My grandmother had it, so I'm doomed.
The genetic fatalism. Yeah.
But you found a statistic in the data that it completely upends that narrative.
This is probably the biggest misconception we need to correct right now. If you look at the genetic breakdown, the dominantly inherited forms of Alzheimer's.
The kind where if you have the gene, you're absolutely getting it.
The very same. That kind where a specific mutation guarantees you will get the disease is incredibly rare. We're talking less than 1% of all cases.
Less than 1%. That is a staggering disconnect from public perception. I think most people operate under the assumption that it's like a 50-50 coin toss if it's in the family tree.
It's really not.
Yeah.
Now, that doesn't mean genetics are irrelevant, and we will absolutely get into the nuances of susceptibility.
Sure.
But the idea of a direct, inevitable genetic sentence is the exception, not the rule. It changes how we should view the risk.
How so?
It shifts the conversation from inevitable fate to complex biology that interacts with how we live.
So let's dive into that 1% for a second, just to clear it off the table, and then we can look at the other 99%. The sources distinguish between early onset and late onset. That 1%, that falls into the early onset bucket, correct?
Correct. When we say early or young onset, we usually mean symptoms appearing before age 65, sometimes much earlier, like in your 40s or 50s.
Wow.
And in these rare cases, more than half are linked to specific alterations on chromosomes 1, 14, or 21. If you have those specific mutations, the inheritance is dominant, meaning if you get the gene from a parent, you get the disease.
But again, just to hammer this home, that's a tiny, tiny slice of the pie.
A very tiny slice.
Yeah.
The vast majority of what we deal with in medicine is late onset AD.
And this is where the picture gets, well, a lot muddier. It's not a single broken switch. The text talks about susceptibility genes, specifically apolipoprotein E, or APOE. The APOE gene.
But the phrasing is careful here. It describes an interaction. It's not a cause.
That's the key word. Interaction. Having a certain version of the APOE genotype puts you at higher risk, yes. Specifically, the APOE4 allele is the risk factor. The more copies you have, the higher the risk.
It is not a sentence.
Not at all. It's a susceptibility that interacts with environmental factors. It's nature dancing with nurture.
Yeah.
You can have the APO allele and never get the disease, or not have it and still develop AD.
And those environmental factors, are those things we might actually have some control over?
To an extent. We're talking about age, obviously, which is the single biggest risk factor we can't control.
Right. But also head injury, depression, and crucially, vascular health. The health of your heart and blood vessels, hypertension, cholesterol, diabetes, is intimately tied to the health of your brain.
That makes so much sense. The brain is a hungry organ.
Incredibly hungry. It needs a huge amount of blood flow and oxygen. If the supply lines are compromised by, say, high blood pressure or clogged arteries, the risk for everything, including AD, goes up.
That's a powerful reframing. It moves it from fate to risk management. It suggests that taking care of your heart is, by proxy, taking care of your brain.
That's a huge takeaway for anyone listening.
Okay, let's shrink down. Let's go inside the skull. If we were to look at the brain of a patient with AD under a microscope, what is the smoking gun? What does the crime scene look like?
The pathology is defined by two major culprits. You'll see these terms in every single paper: neurofibrillary tangles and amyloid plaques.
Tangles and plaques. Okay. I want to make sure we understand exactly what these are, because they seem to attack the neuron from two different directions, inside and out.
That's the right way to visualize it. Let's start with the inside job. The neurofibrillary tangles, or NFTs, these occur within the neuron itself.
So inside the brain cell.
Yes. They are caused by a protein called tau.
Now, normally tau is a good guy, right? It's part of the structural integrity of the cell. I read it described as being like railroad ties.
That's a perfect analogy. Think of a neuron's internal structure, its microtubules, as a railway system that transports nutrients and other essentials from one end of the cell to the other.
Okay.
The tau proteins are the ties holding those tracks together. They stabilize the structure. But in Alzheimer's, this protein gets hyperphosphorylated.
There's that word again. So what does that mean chemically?
It means too many phosphate groups get attached to it. And this chemical change makes the tau protein sticky and misshapen. It causes it to detach from the tracks.
So the railroad ties pop out and start clumping together.
Essentially. The structure collapses, the tracks fall apart, and these rogue tau proteins twist into insoluble tangles inside the cell. The cell's transport system grinds to a halt. It starves.
And here is the critical insight from the research that I saw. The density of these tangles correlates directly with the severity of the dementia.
Directly. The more tangles you have, the worse the cognitive decline. It is a direct marker of how much internal damage has been done to the neurons.
Okay, so the cell's internal skeleton is collapsing. Meanwhile, outside the cell, we have the second villain, the amyloid plaques.
Right. These are extracellular. They happen in the spaces between the neurons. This is an aggregation of a protein fragment called beta amyloid.
So this is like junk building up in the alleyways between the buildings.
Another great analogy. It forms these hard, insoluble clumps or plaques, particularly in the cortex and the medial temporal lobe areas, crucial for memory and higher thinking.
And I've heard that described as gumming up the works. Is that accurate? Does it just block the signal between cells?
It does more than just block. It creates a toxic inflammatory environment. The immune cells in the brain try to clear this junk away, which causes inflammation, which in turn damages the surrounding neurons.
So you have a two-pronged attack.
Exactly. You have the internal collapse from the tangles and this toxic accumulation of plaques outside. The result is the physical degeneration of the neurons. The synapses.
The connections where information lives.
Yes, the synapses fail, the neurons die, and eventually you get cortical atrophy. The brain physically shrinks.
That's terrifying.
It is. If you look at an MRI of a severe AD patient next to a healthy brain, the difference is stark. The ventricles, the fluid-filled spaces in the middle of the brain, are massive because the brain tissue around them has withered away.
It's a terrifyingly efficient system for destroying communication. And speaking of communication, we need to talk about the chemistry, because neurons don't just touch each other, they send chemical messengers.
The neurotransmitters.
Right. And the text highlights a specific cholinergic deficit. Can you break that down for us?
This is central to understanding why we use the drugs we use. The most prominent chemical deficit in AD is the loss of cholinergic activity. We are talking about the neurotransmitter acetylcholine.
And acetylcholine is the primary driver for memory and learning, right?
It's essential for processing information, attention, and laying down new memories. In AD, the cells that produce and use this chemical are dying off at a high rate.
So the plaques and tangles are killing the acetylcholine factories.
That's the running theory. The loss of cholinergic activity tracks very closely with the clinical stage of the disease. The less acetylcholine activity you have, the more severe the cognitive loss.
So the chemical imbalance is a symptom, a direct result of the structural death.
Exactly. And it triggers a domino effect. It's not just acetylcholine. The text mentions that serotonin and norepinephrine systems also take a hit.
Which would affect mood and alertness.
Right. You see changes in enzymes like monoamine oxidase type B, which goes up. The whole chemical ecosystem is thrown off balance.
But there's another mechanism that I found particularly fascinating involving glutamate. It's a concept called excitotoxicity. I had to read that a few times because it sounds so paradoxical.
Yes, excitement toxicity. Yeah.
It sounds like the brain is getting too much stimulation.
That's exactly what's happening. And it's why understanding the chemistry is so important for treatment. Glutamate is the main excitatory neurotransmitter in the brain. It's the gas pedal for neurons. It tells them to fire.
So you need it. It's not a bad thing.
You absolutely need it for learning and memory.
Yeah.
But it's all about balance. In a healthy brain, glutamate is released, it does its job, and then it's quickly cleared away. In AD, the regulatory pathways break down.
So it's just hanging around.
It's hanging around, constantly stimulating the neurons' receptors. The neurons get stuck with the gas pedal floored. They're overstimulated, overexcited, to the point where they let in too much calcium, which triggers a cascade that ultimately kills them. They burn out.
So you have a lack of the memory chemical, acetylcholine, and an overdose of the excitement chemical, glutamate, effectively frying the circuitry.
It's a chaotic chemical environment. You have silence where you need signal and screaming where you need quiet. And this biological chaos is what manifests as the clinical decline we see on the outside.
Which brings us to the what? The progression. This isn't something that happens overnight. It's a slope. And the clinical texts categorize this slope using the MMSE, the Mini Mental State Examination.
Right, the MMSE is a 30-point questionnaire. It's a quick and dirty way to get a snapshot of someone's cognitive function.
So can we walk through these stages? Because I think the nuance between mild and moderate is often missed by families, and knowing where someone is on this curve is vital for care.
It is. And understanding these distinctions is vital for caregivers to know what to expect. So we start with mild AD. On the MMSE, this is a score roughly between 26 and 18.
To the casual observer, does this look like dementia yet? Or just normal aging?
It can be very subtle. It's often dismissed as just getting old. The primary hit is short-term memory. Difficulty with recent events. You remember your wedding day from 1960 perfectly, but you can't remember what you had for breakfast or who called on the phone 10 minutes ago.
But the text notes that it starts impacting instrumental activities of daily living. That sounds like more than just memory.
It is. It's executive function. It's the ability to balance a checkbook or sequence the steps to cook a meal. You might see someone who is a master chef suddenly struggling to follow a simple recipe because the sequencing logic is failing.
So they might put the ingredients in the wrong order or forget a step.
Or forget they're cooking altogether. And there is a major safety red flag in this stage: driving.
That feels like the flashpoint for so many families. The conversation about taking away the keys.
It usually is. A patient in the mild stage might drive to the grocery store they visited for 20 years and suddenly not know where they are or how to get home. Visuospatial skills start to decline.
That's usually the crisis point that forces a diagnosis. What about the psychological state of the patient here? Are they aware of what's happening to them?
Often, yes. And that's part of the tragedy of this stage. It leads to withdrawal. They realize they can't keep up, so they stop trying. They quit hobbies. They stop going to social gatherings because following a fast-paced conversation is too exhausting.
Or, the text says, they go the other way into denial.
Right. I'm fine. Everyone forgets things. It's a defense mechanism against a terrifying reality that they can feel slipping through their fingers.
Then we slide into moderate AD. MMSE scores drop to between 17 and 10. The text describes this as an escalation.
This is where independence is effectively lost. The patient now needs help with basic activities of daily living, getting dressed, grooming, bathing.
Things we all take for granted.
Completely. And the disorientation deepens significantly. It's not just getting lost in the neighborhood, it's losing track of the year, the season. They might think it's 1985. They might ask for their parents who have been gone for decades.
And the memory loss. It goes further back.
It erodes personal history. Forgetting the names of friends or even close family members. They might recognize a face, but not the name or the relationship. You seem familiar, they might say to their own child.
That's just heartbreaking.
And this is where the behavioral shifts really become painful for the family. We see suspicion, paranoia, delusions.
The text mentioned tearfulness and delusions, like believing a family member is stealing from them.
That is very common. The brain can't process the environment correctly, so it invents a narrative to explain the confusion, and often that narrative is fearful. I can't find my wallet, therefore someone must have stolen it. It's a heartbreaking logic.
And physically,
Driving is absolutely out of the question here. The decline is noticeable day to day. This is often when families start looking into long-term care because the needs are just too great.
and finally, severe AD scores from 9 down to 0.
This is the stage of total dependency. 247 care is required. We see the loss of speech, the ability to walk, the ability to feed oneself.
It's a complete return to an infant-like state.
In many ways, yes. And the physical breakdown is complete incontinence of both urine and feces. It brings us back to that definition we started with. It is a loss of physical functioning alongside the cognitive. The brain can no longer command the body.
It's a brutal, brutal progression. Now, you would think with such a distinct clinical picture, diagnosis would be straightforward. But looking at the source material, diagnosis seems to be less about finding Alzheimer's and more about ruling out everything else.
It is fundamentally a diagnosis of exclusion. We don't have a simple blood test that lights up red for AD in a standard clinic yet, though research on biomarkers is advancing rapidly. So for now, clinical diagnosis is about eliminating the mimics.
Well, let's talk about these mimics, because this is actionable information for our listeners. What else looks like dementia but isn't?
A surprising amount of things. This is why you never, ever just assume it's Alzheimer's without a full workup. Number 1, vitamin deficiencies. Specifically, vitamin B12 or folate deficiency can cause cognitive slowing and memory issues.
And that's easily treatable.
Completely. A few shots or pills and the problem can resolve. Thyroid problems. Hypothyroidism can make you sluggish, depressed, and confused. Electrolyte imbalances, these are all reversible.
And then there is the medication list. I was genuinely shocked by the concept of drug-induced dementia.
We call it the anticholinergic burden. Remember, AD patients are already low on acetylcholine.
Yeah.
So if you give an elderly patient a drug that blocks the acetylcholine, which many common drugs do as a side effect, you can induce dementia-like symptoms.
You're essentially giving them a temporary chemical form of Alzheimer's.
In a way, yes, you're chemically suppressing their cognitive function.
What kind of drugs are we talking about here?
Are
Are
they
they obscure?
Not at all.
Yeah.
Very common ones. Sedatives, certain pain medications like NSAIDs in high doses, corticosteroids, even digoxin for the heart. Antipsychotics are major culprits.
Wow.
Even over-the-counter sleep aids or allergy meds, like Benadryl, can have strong anticholinergic properties. If an elderly patient suddenly gets confused, the first thing a good doctor does is not order an MRI, it's check their medicine cabinet.
That is such a critical takeaway. You could be treating a backache or insomnia and accidentally causing cognitive decline.
It happens all the time.
So the tools for diagnosis are, first, a thorough patient history.
Right. Asking about alcohol use, head trauma, depression, then imaging. We use a CT or an MRI, but mostly to rule out other things.
So we're not looking for plaques on the MRI.
Not on a standard MRI. You're looking to make sure it's not a brain tumor causing the symptoms, or a series of small strokes, or a condition called normal pressure hydrocephalus.
Okay, so you rule out the big, obvious structural problem.
Exactly. And then we use the MMSE to establish a baseline.
And once that baseline is set, we watch the trajectory.
Exactly. In an untreated patient, we expect the MMSE score to drop by about 2 to 4 points per year. That gives us a benchmark.
Yeah.
If they drop faster, maybe something else is going on. If they drop slower with treatment, we know we're having an effect.
So let's say we've done the detective work. We've ruled out the thyroid, the vitamins, the bad drug interactions. We are left with Alzheimer's. We have to treat it.
And here we need to manage expectations immediately. The text is very blunt, and I think we owe it to the listeners to be equally blunt. The goal of pharmacotherapy is maintenance.
Not a cure.
Not a cure. We are not reversing the damage. We are trying to keep the patient at their current level of function for as long as possible. And if we stop the drugs, any benefit is lost.
And the metric for success is, well, it's relative. It's kind of bleak.
It's tough. If we put a patient on medication and after a year they've only dropped by 2 points instead of the expected 4, that is considered a clinical success. We're buying time. We are slowing the decline.
Success is declining slower. Okay, so let's look at the toolkit. We have 2 main classes of drugs. First up, cholinesterase inhibitors. The names are donepezil, rivastigmine, and galantamine.
These are the first-line drugs for mild to moderate AD.
So how do these work?
They go back to that cholinergic hypothesis we discussed.
Mm.
Imagine your brain is a sink and the acetylcholine is the water. In AD, the faucet is broken and barely trickling water in because the cells are dying.
Okay.
These drugs act as a plug for the drain. They inhibit the enzyme acetylcholinesterase that normally breaks down acetylcholine, so they keep the little bit of water you have in the sink for longer.
That's a great analogy. So we are boosting the signal by preventing the messenger from being destroyed. But there's a catch. Acetylcholine works everywhere in the body, not just the brain.
Exactly. It works in the gut to promote digestion and movement. So when you boost it systemically to help the brain, you overstimulate the gut.
Which means?
That leads to the primary side effects. Nausea, vomiting, diarrhea, weight loss. This is a real problem for elderly patients who might already be frail and underweight.
And what about the heart?
You can also get bradycardia, a dangerously slow heart rate, because acetylcholine slows the heart. It's something we have to monitor closely.
And there was a specific warning in the text about stopping these drugs. You can't just quit cold turkey.
No, if you stop abruptly, you pull the plug on the drain. The acetylcholine levels crash, and you can see a rapid, often permanent worsening of cognition. The brain has adjusted to the drug, and removing it shocks the system. It has to be tapered.
Then we have the second tool, which is used for the later stages, memantine.
Right. This is for moderate to severe AD, and it targets that other issue we discussed, excitotoxicity.
The gas pedal being stuck down.
Exactly. If the cholinesterase inhibitors are plugging the drain, memantine is trying to unspick the gas pedal. It's an NMDA receptor antagonist. It blocks those glutamate receptors just enough to prevent that toxic overstimulation, but ideally still allows normal signals through.
So it's more about protecting the brain from further damage than boosting a signal.
That's a good way to put it. It's neuroprotective.
Can you use both, the drain plug and the gas pedal fix?
Yes, and often we do. Memantine can be added to Dunpezil in moderate to severe cases, and generally, memantine is better tolerated. Less of the GI upset, though it can cause some of its own side effects like confusion, dizziness, or constipation.
I think it's just as important to talk about what doesn't work, because when people are desperate, they are vulnerable to snake oil. The text lists a few things that come up constantly in forums but have no clinical backing.
Right. The list of don'ts is very clear in the literature, and it's important to go through them.
Okay, first one, estrogen.
Nope. Big trials were done. No benefit found for prevention or treatment.
Vitamin E.
Not recommended. Some older, conflicting data. But the current consensus is that the risks outweigh any potential tiny benefit.
NSAIDs like ibuprofen or Alev, people think, well, there's inflammation, so maybe.
It's a logical thought, but no, not recommended. No evidence they help the dementia, and they come with a high risk of stomach bleeding and kidney problems in the elderly. Same for prednisone.
Statins, the cholesterol drugs.
Great for your heart, and by extension, good for long-term brain health from a vascular perspective. But the trials haven't shown they treat or slow down existing AD symptoms specifically.
And the big one, ginkgo biloba. I see this in every health food store labeled brain health.
This is one where the marketing has totally outpaced the science. The data on efficacy is weak and inconsistent at best, but more importantly.
It's not just that it doesn't work, it can be dangerous.
Exactly. The products are often poorly standardized. You don't know what you're getting, and it carries a genuine risk. Bleeding. It can act as a blood thinner.
And many elderly people are already on blood thinners for heart conditions or stroke prevention.
Correct. And considering the AD population is elderly, many of them are on anticoagulants like warfarin or Eliquis. Mixing ginkgo with those can be incredibly dangerous. It significantly increases the risk of internal bleeding or even a brain bleed. It's a hard avoid from a clinical perspective.
We've covered the memory and the cognition, but earlier you mentioned the behavioral shifts, the wandering, the agitation, the sleeplessness. These are often the things that break a caregiver's ability to cope at home.
They are. They're what lead to burnout and institutionalization.
So how do we treat those?
The text is emphatic here, and all modern guidelines agree. Non-drug first. Always.
What does that mean in practice?
It means if a patient is wandering or agitated, you change the environment before you reach for a pill. Is the room too dark? Are there shadows that look scary? Is there too much noise? You establish a firm, predictable routine. You remove triggers. You use calming music. You redirect. Because the pharmacological options for behavior are fraught with danger.
You're referring to antipsychotics?
Yes. Historically, these were used to sedate difficult patients, essentially as chemical restraints. But the modern data is alarming. First, they barely work.
Barely work?
The stats are dismal. Only about 17 to 18% of patients show even a modest response. For most people, it's no better than a placebo. But the risks. The risks are massive.
What kind of risks?
Worsening cognition, so the drug you're using to manage behavior makes the dementia itself worse. Abnormal gait leading to falls and hip fractures, which is often a death sentence for a frail elderly person. And the FDA has issued a black box warning.
That's the most severe warning the FDA can put on a drug. What is it for?
Increased risk of death. Using atypical antipsychotics in elderly dementia patients increases mortality, mostly from stroke and infection. It effectively shortens their life.
That's a stark, horrifying calculation, a drug that probably won't work and might kill you.
Which is why the guidelines now say they should rarely be continued beyond 12 weeks, and only when the behavior poses a severe, immediate threat to the patient or others. It is a last resort, not a first line.
What if the behavior is driven by depression? We know that overlaps significantly with dementia.
That's a great question. If it's truly depression, we should treat it. But again, we have to be very selective with our tools.
So what's the go-to?
We use the SSRIs, like sertraline or citalopram. They are generally safer and better tolerated. We strictly avoid the older tricyclic antidepressants, like amitriptyline.
Why avoid those?
Because they have strong anticholinergic effects. They block acetylcholine.
Oh, wow. So they're fighting directly against the main Alzheimer's drugs.
Exactly. We would be undoing everything we are trying to achieve with the Donepezil. We'd be treating the mood, but destroying the memory. It all circles back to that core biological mechanism.
It really is a delicate, complex balance. You're trying to boost one chemical, dampen another, manage side effects, and avoid interactions, all in a brain that is physically shrinking.
It is high-wire medicine, and that is why having a specialist, a geriatrician or a neurologist who understands these interactions is so important. This is not something to be managed with a simple prescription pad.
So we've deep-dived the biology, the progression, the diagnosis, and the treatment. We've seen the mechanics of the plaques and tangles. What is the final takeaway here? If someone listening is staring down this diagnosis for a parent or a spouse, what is the one thing they need to grasp?
That education is the most powerful intervention we have. The text explicitly states that the most vital step upon diagnosis is educating the patient while they can still process it, and critically, the caregiver.
So getting ahead of it.
Getting ahead of it. You need to make legal decisions, early power of attorney, living wills. You need to understand that the trajectory is down so you can prepare the home environment for safety. You need to know that fixing the behavior might not be possible with drugs, so you have to learn to fix the surroundings and the approach.
It's about adaptation, not denial.
Precisely. And I think it leaves us with a provocative thought about modern medicine. We have mapped this disease in incredible detail. We know the proteins, the enzymes, the genetic alleles. We can see it on a PET scan. And yet, our best strategy is still maintenance.
It's still management.
It is. And it forces us to ask, is the goal of medicine always to fix the machine? Or in cases like this, is it about maximizing the quality of the human experience as the machine inevitably changes? Right now with Alzheimer's, we are firmly in the latter camp. We are shepherds of decline, not mechanics of repair.
That is a humbling and very powerful perspective. We know the mechanics of the breakdown, but the repair is still out of reach. We have to focus on the human in the midst of the biology.
Thank you for walking us through this. It's heavy, but clarity makes it more manageable.
Knowledge is the best armor we have against the fear.
Thanks for listening to this deep dive. Take care of your brains, and we'll see you on the next one.